Hi, everybody. Good morning. I'm Dr. Steve Wolf, the Director of Pediatric Epilepsy at Boston Children's Health Physicians of New York and Connecticut, and the Director of Pediatric Epilepsy at Maria Ferrari Children's Hospital at Westchester Medical Center.
And I'm Patty McGoldrick, nurse practitioner. I'm his partner. We are a level 4 pediatric epilepsy center at Maria Ferrari Children's Hospital and Boston Children's Health Physicians. Today, we're going to talk to you about living with epilepsy and pediatric epilepsy treatment. And we thank you all for being here this morning. We really appreciate you tuning in, and we hope what we'll say will be useful to you.
Hold on a second. Here we go. So we're going to talk about epilepsy and really an overview. What is seizures? And basically, just to let you know, seizures is a surge of electrical activity in the brain.
But epilepsy is recurrent, unprovoked seizures that are not caused by a known medical condition.
There are many things that can cause seizures. Most of it we really don't know. We call that idiopathic, which means we're idiots because we don't know why. But we know that certain things clearly can cause seizures, such as malformations of the brain, some genetic disorders, trauma to the brain, tumors, blood clots, strokes, infections, and even metabolic disorders.
The incidence of epilepsy by age. Now, this is an old graph, but it has not changed over the years. So if you look over at the one side of the graph, that is the incidence of seizures in neonates, in newborns. So newborns, young infants have a higher incidence of epilepsy and seizures. And then as you get through childhood and into adulthood, it sort of levels off and there's not that many people who have epilepsy, but then it increases again exponentially as they get into the older years. So 70 and above, there's a higher incidence of epilepsy again.
But what's really important is when someone has more than one seizure, we need to figure out, is this epilepsy? And how do we diagnose epilepsy? And really, it's the medical history. It's doing testing like an EEG test, doing a scan on the brain, such as an MRI or a CAT scan. And nowadays, we really think it's genetics. And all this is to really help the family go through what's called the diagnostic journey to get to the bottom of why someone's having seizures. And it's really important for the families to know that we've looked at every single possible reason of why somebody can have seizures. It's important if we can classify the type of seizures or the reason they have seizures, that helps the family get support. And maybe if it's genetic, some genetic counseling for the family members. It's also important to find out what type of epilepsy you have. Do you have focal seizures where it starts in one area of the brain, or does the whole brain turn on at once?
And we figure that out by doing the EEG, which is the testing of the brain waves. So you're not alone. You and your family member are not alone. There are about 70 million people worldwide who have epilepsy. And of that 70 million, almost 3.5 million in the United States have epilepsy. It's the fourth most common neurological disorder in the nation, and there are about 150,000 new cases of epilepsy diagnosed in the United States each year.
It's a lot of people. Now, the classification, how we think about seizures is not exactly based on how the seizure looks by the time you go run in to see your loved one who's shaking. It's how the seizure starts inside the brain. So we break it up into sort of 3 areas. Focal, which means it starts in one little area of the brain and then spreads. And in that category, you can have what's called aware seizures and unaware. Aware means like you know they're happening. You can actually converse with your loved one and talk to your family while it's happening. Or impaired is that you have no idea what's going on. And then the motor phenomenon, what the seizure looks like, can depend on every single patient, depending on where the seizure starts in the brain. So it could be motor just involving the arm or motor just involving the leg, or it might not have any motor and just have like some weird lip smacking or staring with it. Sometimes the seizure can start in one arm and then move over to the other arm, or the whole body can shake in sort of this what's called tonic-clonic shaking. It's not unusual to have a focal seizure spread to the rest of the body.
Now, that was focal onset or localization related epilepsy. So that starts in one area of the brain and may spread. The other big type of epilepsy is generalized, which means that the whole brain has a big burst of electricity all at once. those seizures are the ones that look like generalized tonic-clonic seizures. So they're mostly what people think of as a seizure. Those are motor, so that involves motor movements in the body. There are also ones that are non-motor, and those are absence seizures or staring spells. So those are more often diagnosed in children, and they have these vacant stares, maybe with a little eye movement. Under the generalized category, there are also other ones. There are spasms, there are myoclonic jerks, there are tonic seizures where the person just gets very stiff, and there are atonic seizures where the person drops. Those are the people that you see wearing helmets to protect their head from sudden falls.
There's also a group of seizures where we just don't know where they start. And we're not sure if they're generalized or focal, or they actually might be a mixture. So every once in a while, your medical provider might say to you, I'm not exactly sure what type you fall into. I think we need a little bit more time to figure it out.
And that's when we repeat the tests. So let's talk about how we treat seizures. There are three main ways. The mainstay of treatment for epilepsy is anti-seizure medications. We used to call them anti-epileptic medications, but they don't cure the epilepsy, they stop the seizures. The second category is diet, which we'll talk about later, and the third is surgery. So the benefits of the medications or the anti-seizure medications to be used for epilepsy are that they work most of the time in about 7 out of 10 people. There are different medications. That's why we need to find out, is it a focal or localization related seizure versus a generalized seizure? And that determines which medication we should use. And there are more than 25 anti-seizure medications available now. What we do is we look to see the age of the individual, what their other comorbidities might be, whether it is a woman who's going to have children, and we try to tailor the treatment based on those factors.
But we do have to be aware and discuss the limitations and the risks of anti-seizure medication. There's always a risk of side effects such as drowsiness, dizziness, confusion. And this is really important to discuss with the family, and the family to be really aware of, because we don't want your loved ones having any side effects. And if they do, you need to discuss it with your primary care provider or your neurology provider, care provider, so we can adjust the medication. And again, the probability of seizure freedom declines every time you add another medication, because usually after the third medication, things don't start working. They still continue to have seizures and they don't work that well.
It's also important to realize that side effects may happen, but sometimes the list of side effects that you're given from the pharmacy is really extensive and very scary. So it's important to talk to your provider and ask. We'll usually tell you what the most common side effects are and what to look out for and when to call us.
That doesn't mean you're going to get every side effect of the medication just because it's listed. It means there's a risk of it.
Now, what Steve just was talking about when we showed the last slide is that in 7 out of 10 times the medications do work, but with each subsequent medication, there's less and less chance that an additional medication is going to work. So about a third of the people, 3 out of 10, do not achieve seizure freedom with medication. So the studies have shown, and there have been extensive studies looking at this, that if you didn't achieve seizure freedom after the first medication and the second medication, only 4% of people will achieve seizure freedom after the third medication. And just an aside about the way that we determine this, we start with the correct medication, as I said, for the type of seizure with the fewest side effects. You increase that medication dose until it's the highest dose possible with the fewest side effects. And then you add a second medication. And at that point, what you should be doing is trying to get rid of the first medication so that people don't stay on 3 and 4. Now, many times you do need to stay on more than one, but that's always the goal.
So let's talk about comorbidities. These are things that patients with epilepsy can have in addition, other disorders that you can have in addition to having seizures. We know that patients with epilepsy have a high frequency of learning disabilities, attentional issues, anxiety, depression, cerebral palsy, which is motor issues such as walking, grabbing, using your hands, feeding issues, autism in about 20 to 40% of children, as well as cognitive issues. So all these are the extra baggage that can come along with epilepsy, and you have to address and treat each of these issues as well as you're treating the epilepsy.
We also really try to tell people who have an individual in their family with autism that there is a pretty big chance that they may have a seizure or develop epilepsy sometime in their life, so that no one is taken by surprise when that happens.
So Welcome to Holland is a short, basically, story, which is when we talk about basically you expect to be pregnant, have a normal child, the child to do great, everything to do fine, and then you end up in the world of a child with epilepsy. And this is about you're planning a trip to Italy, you read all about going to Italy, you packed all your clothing for Italy, you're ready to go to Italy, you get on the plane, and when you land on the plane, you're in Holland. And you're like, what am I doing in Holland? I'm not prepared for Holland. I'm not happy to be in Holland. I'm angry. It's not what I expected. And you're just really frustrated. And you have to sort of learn a whole new what's Holland? How am I going to enjoy Holland? And basically, having a child with epilepsy, you weren't expecting it. But yet, Holland's a nice place. And if you get to know it, it's a wonderful place. And if you're angry and frustrated about it, and you're always mourning the fact that you didn't get to go to Italy, you're never going to appreciate where you're at. And with epilepsy, once you conquer that initial fear and anxiety, there's a lot of positive things, and not to take away from learning how to take care and treat the loved one that you have in front of you with epilepsy.
One of the big things when people come in the first time they or one of their loved ones has had a seizure is, first thing they ask is this going to happen again? The second thing is, how do we treat it? And the third thing is my loved one going to die of a seizure? So SUDEP, or sudden unexplained death in epilepsy, is real. It's a real phenomenon. We probably don't talk about it as much as we should. There's about 1.16 cases of SUDEP per 1,000 people with epilepsy. The people that are at the most risk are those who have generalized tonic-clonic seizures, who have frequent generalized tonic-clonic seizures, frequency meaning 3 or more per year, men in their 30s who also have an associated developmental disability. Also, if you fail to add an additional anti-epileptic medication when patients are refractory, so that's on us. So we try to then, if you're having a seizure, we don't want any breakthrough seizures. We want to make sure that you're well controlled, and if that means adding another medication or increasing the dose, we're going to do that to prevent SUDEP. We want people to be seizure-free for anywhere between 1 and 5 years before we wean them off the meds. And there is a cause. We think that SUDEP has something to do with an abnormal heart rhythm and breathing difficulty. And what we ask you to do is to have supervision at night and to have some sort of seizure detector going on in the room, especially people who are sleeping alone. And we're going to talk about that a little bit more.
So what kind of treatment options are there? So we're going to talk a little bit about medications. And in this lecture series, you'll be hearing from other doctors who are to be talking about new medications. We're going to talk briefly about seizures for refractory epilepsy that we do in children. So the most important thing is to focus on personalized medicine. And really what we're saying there is to understand and clearly diagnose what type of epilepsy your loved one has. Do they fall in the category of something called Lennox-Gastaut, which are seizures that onset in childhood, they persist into adulthood, they have a significantly abnormal EEG with multiple seizure types, such as drop seizures, generalized tonic-clonic seizures, atypical absence seizures, and these children also have developmental delay. So if you can get diagnosed into this category, it opens up a whole world of a resource of a family organization, as well as new medications that are really just tested on patients with Lennox-Gastaut.
There are several epilepsy syndromes that start in childhood. Lennox-Gastaut is one of them. Dravet syndrome is another one. So Dravet syndrome starts with seizures in infancy. And these seizures occur when there's a change in temperature, either with a fever or going from hot air into a cold pool or cold air into a hot bath. It's a sodium channelopathy, which means that there's a problem with the sodium channels that control the neurons. These people have long seizures and they may develop a movement disorder. They may also have some degree of intellectual disability. The important thing about identifying Dravet's is that there are certain medications that can make the seizures worse. And they also need a specific rescue medicine that works better for people with Dravet syndrome.
Tuberous sclerosis is another genetic disorder that's a multiple system disorder. So this genetic disorder affects the brain, affects the skin, the heart, the kidneys, and they can have infantile spasms as well as autism. And then CDKL5 is another genetic disorder that also has really difficult to control seizures, and we call it an atypical Rett syndrome. This is another difficult, very specific, different than Lennox-Gastaut kind of seizures.
So there's some recently approved newer medications that are specific to treat these syndromes. It's important to go back to your provider and say, did you identify my child or my loved one as meeting the criteria for one of these syndromes? Because if they do meet the criteria, there are certain medications that are newer and that work better than the old medications. And this is not limited to children, because there are many adults whose seizures started in childhood, but never had the genetic testing and never had the work done to see if they really did meet these criteria. So the newer medicines are Ztalmy or ganalaxone, which is approved for the treatment of seizures associated with CDKL5, which is the atypical Rett's. Fintepla or fenfluramine treats the seizures associated with both Lennox-Gastaut syndrome and Dravet syndrome in patients 2 and older. Valtoco and Nasalam are the nasal sprays used for rescue meds. We'll talk about that a little later. In the past, we had only, we used a wafer formulation, or we used rectal diazepam. And now in the last 4 years, they have come out with new nasal sprays, which are much easier to use, much easier for caregivers, and with much less social impact.
But as you get the point that Patty's mentioning is genetics is really important. Making sure that your loved one has been evaluated, no matter what age, with the new and recent genetic testing, which might help you diagnose, say, Dravet's or CDKL5. The other medications that are also available are dicominate, steripental, which is also indicated for Dravet's, and Epidiolex, which is an FDA-approved cannabidiol, which is approved for not only Lennox-Gastaut, Dravet's, but also tuberous sclerosis, and Xcopri, which is a sodium and a GABAergic drug, which was approved for children 16 years old and older for focal seizures that spread throughout the brain. We'll just briefly talk about dicominate because it's, again, indicated for Dravet's, but it's a unique medication. It's been around in Europe. It works on GABA drugs. It can cause side effects, but it's a really good drug to try if your loved one's still continuing to have seizures. There are some new studies that are going on out there with new molecules that are different than the anti-seizure medications that you are getting on the market. And so if your loved ones has already failed a number of other medications, it's really important for you to go back to your medical provider and say, hey, are there new drugs that I might be eligible for drug studies? And these are a list of 4 of them that are currently ongoing in the United States.
All right, so we talked about drug-resistant epilepsy. So these are people that have failed. These are not people that have failed 7 or 8 or 9 medications. They are anyone who has failed 2 medications. They've taken 2 different medications that are the correct medication for the type of epilepsy that they have, and they ratcheted it up to the appropriate dose, and they still had seizures despite taking the medication correctly. We don't know why people become drug resistant, but we think some of these factors that you see here on this slide may be part of the reason. So the severity of the epilepsy, the comorbidities that exist at the same time, maybe an inflammatory process. The drugs may be targeting something that really is not going to work to decrease the seizures. They can have brain tumors, they can have alterations in the networks, and often we just don't know why some people become drug resistant. But that's when we go into the different treatment options. So this is Nasalam, that's one of the rescue meds. So this is a nasal spray, it's midazolam. It's used for treatment of seizure clusters in patients 12 and older. The other medicine is Valtoco, which is intranasal diazepam. That is approved for children 6 and older. We are trying to get FDA approval. That's an ongoing research study for children ages 2 to 5, which hopefully will become forthcoming soon. So it's much easier to use both the Nasalem and the Valtoco instead of the rectal diastat. But if you are under 5, rectal diastat is still an important thing to have, and it's important to have a seizure action plan so that you can obtain treatment at school or at work, or for people that live in facilities in their homes.
Now, say your loved one continues to have seizures and continues not to respond to medication. There are surgical options. And this is a conversation that you should have early with your neurology provider to see, are we possibly a candidate? And what kind of testing needs to be done to consider if you are a candidate for surgery.
And as you can see, these are all the different types of surgeries that are available. We're going to talk a little bit about some of them. This picture is of grids. It's an EEG placed directly on the brain. We also have another way of doing it, which we use little burr holes and place the electrodes deep into the brain. So we'll talk about that a little bit. Okay, so surgical options. So this is the workup. How would you decide if you are a surgical candidate? Obviously, if you had failed medications, you need a full health assessment with a medical history. You need to stay inpatient in an epilepsy monitoring unit, usually for a few days while we titrate the meds and take you off some of the meds to provoke seizures. We also do special MRIs and PET scans and a neuropsychological evaluation. And then we have a big conference with all of the providers to decide if we can move forward to surgery and if the individual is an appropriate surgical candidate.
So the most important thing is, what are your options? So before you can even get to surgery, you need to figure out exactly where the seizures come from. And that was what Patty mentioned about stereo EEG and grids and strips. Those tests are basically our homework to figure out what are your options for the surgery. Even though those are surgeries themselves, because you have to place electrodes in the brain to figure it out, that's not the corrective surgery. That's not the cure. That's the homework, trying to figure out what type of seizure you have and then what options you have. So just even doing the stereo EEG or the grids and strips will allow you to decide, am I a good candidate for minimally invasive surgery like a laser? Am I a good candidate for neuromodulation like a brain pacemaker such as RNS or deep brain stimulator or vagal nerve stimulator? Or am I a candidate for invasive surgery, which means there's a spot that we really see where the seizures are coming on, and then the neurosurgeon can remove it. So stereo EEG, grids and strips, that's just the evaluation part. That's like the colonoscopy part of the test. It is a procedure, but it's not the cure. It's the homework. And then that helps guide us on what the real cure or treatment is.
So again, if you're looking at surgery, you are admitted with the EEG put on the outside of your head, taken off your meds, look to see where the seizures come from in terms of what side of the brain and what area. Then you do a special MRI. You may do a PET scan, which looks at the metabolism of the brain, and you may do other tests, a functional MRI, a WADA test to look where memory and language are. And then after that, we decide if we want to put electrodes in the form of a grid directly on your brain or electrodes in the form of stereo EEG deep into the brain. And we bring you in and do that next. And then after that, we decide which type of surgery or ablation is appropriate for you, the patient. And now we'll talk a little bit about the different things that are available. Now, these are only available at epilepsy centers, and we didn't really talk about level 4 epilepsy centers. So it behooves you as a patient to have all of this workup done at an epilepsy center where this is done all the time.
So minimally invasive laser ablation is usually after someone's either had a stereo EEG, an MRI, and you really localize exactly where that spot is where the seizures are coming from. And basically with a robotic guided system, an electrode is placed in that spot where the seizures come from. And then the laser burns the area where the seizures come from. It's removed. You go home in 2 days, you have a few stitches, and then we wait and see if we precisely burned out the area where the seizure comes from. Responsive nerve stimulation also usually requires a stereo EEG. And again, the idea is to find exactly where the seizures come from on the skull, and to really once you find it out, then if it's an area that's a really important area, these are not areas that you want to cut out. So you basically, this device puts electrodes right on the area where the seizure starts, and the machine detects when the seizure is starting, and then it zaps it back. And this is a great example of personalized medicine because we program everybody's device differently depending on how the seizures are, what we learn about the seizures, what information we gather. And basically, it's a little computer chip, and it collects data, and every night you'll download it with a little wand to your computer, and then you send it to the cloud. And then us neurology providers can look at this data, and then when you come in, we can reprogram your computer chip to better control the seizures. Deep brain stimulation is a little different. It doesn't focus on exactly where the seizure is starting in the brain, and this can be used for focal seizures as well as generalized seizures. And this is basically, the electrodes are placed deep in the brain, usually in the thalamus, which is sort of like the big relay station of the brain. And this sends little impulses to the brain to help zap and prevent the seizures from happening. Vagus nerve stimulator doesn't have any implantation in the brain. It's a little device that's under the skin. It connects to a nerve in the neck, the vagus nerve, and that vagus nerve goes right up into the brain. And the idea is to send little impulses, electricity down up the vagus nerve into the brain, which will hopefully disrupt the seizures from happening. And it also comes with a little magnet. So in case you feel a seizure coming on, you can swipe the magnet and get a little extra impulse, which will hopefully disrupt the seizures. And your medical provider will keep programming it and adjusting it to find the right amount of zapping electricity to help prevent your seizures.
The other option is the open resection. So this was originally the epilepsy surgery that we did before we had the availability of the neurostimulators. So it means opening up the skull, opening up the brain to see where the seizures start. So you look for the area where the seizures start by putting grids over them, grids of EEG electrodes. And then you test to see exactly where those seizures are coming from. And you do brain mapping so that you avoid taking out any area of the brain that would be responsible for motor or language or memory. And so it's a safe procedure. So that area is then resected, and then the skull is closed up, and the hospital stays usually a few days. There are a couple of other options before I go on to the diet, and those are a corpus callosotomy. So people who have drop seizures or atonic seizures, sometimes we sever the connections between the two sides of the brain, and that helps to prevent the drop seizures. So that's another surgical option. And then let's talk about diet options. So diet options are really for the refractory epilepsies. There are certain epilepsy syndromes that they work well in. There is a ketogenic diet where you really eliminate carbohydrates and you eat fat and protein. It's hard to stick to. It's not as simple as it sounds. It requires monitoring supplements, changing your medications to a form that doesn't contain much sugar. Then there's modified Atkins and low glycemic. These are all put into place with the help of a nutritionist and your provider, and you're monitored throughout. Typically, people stay on it about 2 years. The ketogenic diet is easiest for people who either fed via G-tube or for infants who are bottle fed, because there is a formula available for that feeding. And now we're going to talk about getting information on epilepsy. So there is the Global National Association of Epilepsy Centers. If you go on their website, they will give you a list of what epilepsy programs are either a level 3 or a level 4 epilepsy center. And that's where you should be going for most of your information if you have intractable epilepsy. If you don't have intractable epilepsy, your typical epileptology team or neurology team can treat you. Then these other programs, so the CUTE syndrome, the TSC Alliance, Dravet syndrome, the Lennox-Gastaut Foundation, these are all wonderful sources of information and support for the precise syndrome that your loved one has been diagnosed with. We also ask that you keep seizure logs. It's really much easier for us if you come in with information about when the last seizures were, how long they lasted, what they looked like. So there are a couple of online programs. One is Seizure Tracker, and the other is My Seizure Diary. And they are apps that you can download on your phone, and you'll be able to track dose of medications, type of seizures, how long they lasted. It makes it much easier. And then for information, the American Epilepsy Society, the Epilepsy Foundation, the Epilepsy Alliance, Child Neurology Society, the Association of Child Neurology Nurses is also a really good place to get information. We prefer that you go to these sources rather than just Googling, because really some of the information you can get by Googling things is just upsetting. There are a variety of different seizure detection devices. There's an Embrace watch, an Empatica watch. There's a SAMI camera that goes in the ceiling. We ask that everybody wears a medical alert bracelet so that you're easily identifiable and no one is trying to guess whether you're having a seizure or having some other disturbance. And everyone should have a seizure action plan so that their loved ones, their teachers at school, their coaches, their fellow workers and colleagues know what to do in case of a seizure.
There's another really good resource called the childneurologyfoundation.org. And as you scroll down, there's an epilepsy hub, which has lots of also useful information.
And that's it. We thank you all for listening this morning. We're going to take some questions that you can put in the chat, and we really appreciate you being here.
And thanks for advocating for your loved one.
And thanks for having us to speak today.